Mrs. Agnès Buzyn, Minister for Solidarity and Health. And we're going to be interviewing Mrs. Buzyn. Hello, Minister. Hello, Mr. Valencien. Reading the documents about your health strategy, there are 8 words, 8 terms, 8 verbs that speak for themselves: prevent, anticipate, manage, delete, release, recognize, encourage. So we can go through them maybe. We've got 40 minutes ahead of us, and maybe we can go through each one.
So, I must say that the whole vaccine issue, you managed it wonderfully. I really think you chose the right way to do things. How do you see the development of prevention in the country? Let's look at the word prevent, first of all. So what are your ideas and the techniques that you want to use for prevention? Well, before talking about prevention, perhaps I want a consistent and coherent healthcare system. We spend a lot of time cutting it into different sections and pieces, and I'll try to answer each one of these 8 words that you've mentioned, but the reality, it should be a coherent whole. That's the idea. Often we modify the healthcare system in sections, in small pieces, and it loses its global coherency. And yes, I thank Madame Quiles for underscoring the fact that I'm focusing on the long term, and the long term doesn't always pay back immediately. And prevention will allow us to have perhaps the elderly who will be less dependent, less ill 30 years from now, and that will be better for our healthcare system. 30 years from now, we will still need this. So it's the long term that I'm really trying to focus on through prevention. Prevention in every field. This is education to health at school, in the workplace, questions of health and the environment, and obviously questions of behavior. I want the French citizens to change culture with respect to prevention issues. We've been talking about this for 40 years, and yet reality shows us that very little has been done. When I arrived, there were 2 flagship measures that were quite emblematic to really illustrate the commitment of my ministry in terms of vaccination and the price of tobacco. These are 2 emblematic measures, but beyond just the symbol, I really want the French people to take into account the fact that the quality of life and the way you age and their life expectancy depends on their behavior from a very young age. So there will be an interministerial steering committee for health. All of the ministries will have to give a roadmap for these prevention issues. And beyond this, I would say that we don't have the tools available today to encourage prevention. Why isn't prevention developed? Well, because we have a healthcare system that is oriented on care and treatment, and it's done its job very well. It was designed in the 1950s when acute disease was very present. So nothing was focused at the time on prevention. So for this measure to truly be implemented, for me, there is a challenge of pricing. And we need to rethink pricing, and we need to integrate prevention into people's healthcare path. We talked a lot about healthcare paths, and I prefer to talk about health paths from the very young age, where prevention is integrated in this health path and really promoted. And healthcare professionals should be encouraged to invest in these prevention missions. So indeed, prevention impacts healthy people, first of all, in every area, in companies, administrations, schools, in universities, everywhere, to avoid burnout, obesity, addictions, occupational accidents. So don't you think that we should truly create, and this is not the doctor's role. The role of the doctor is to prescribe things. But I think this would be, if we could have healthcare counselors, I think they could help, for example, they could go to nursing school and then maybe have 1 extra year of training, and they could work in companies. You could have 1 or 2 healthcare counselors that would be in the workplace available to employees, for example. That would really change the situation in terms of prevention. Well, I'm not sure that we can say that healthcare professionals should not be talking about prevention to their patients. First of all, patients listen to doctors much more than to the authorities. So I think all of these great prevention campaigns launched by ministries have a much weaker impact than what the doctor tells you. So we need to have this prevention message conveyed by people that the patients trust. So beyond this, we've also planned for what we call a health service for students that will deploy prevention messages as close as possible to students and also in companies close to the employees. But this requires a framework. So we've entrusted a mission to professionals to define the scope of our action, the system and its deployment, and to really equip professionals. We're not going to send nursing students or medical students to go to primary schools to talk about prevention without equipping them with tools and without identifying the objectives. So we do have to set up a framework, and this will allow future healthcare professionals to really integrate the notions of prevention in their professional background. Now, crisis management. You've already been through these different problems with the thyroid medicine crisis and the vaccine crisis. So you seem to be pretty tough in times of crisis. Well, it's not just the crises are never exactly the same. We also had the Hurricane Irma crisis, which was quite different. So in terms of organization is based on past experience, and sometimes it's hard to anticipate what crisis could arrive in the future. So this system of crisis management is already very well equipped. We have what we call the chorus at our ministry with the professionals dedicated to crisis management. It was very much focused on terrorism, terrorist attacks and epidemics and major accidents or climate disasters. But we could imagine that a new crisis could arise and we would have to improve the chorus mechanism. So it is a challenge for my ministry and for the minister and myself. And luckily, in my professional background, I've had a lot of experience with crises because I worked in the resuscitation and I was also in charge with the medical aspects of the crisis at Fukushima. So I am fully aware of the difficulty to anticipate. And the challenge for our ministry is to be able to anticipate what is unexpected. That is what we mean by crisis management. And we have to have a fast response to anything that we didn't expect and be very agile. This agility, I think, needs to be boosted within our organization. Now, in the crisis, Teva, where the wrong drug was put into a box, it took 3 weeks for the gendarme to find out what had happened. So I think maybe you need some kind of health squad with super equipped people who would be able to go everywhere in public and private institutions with chemical and physical resources to help you hour by hour find out what had happened. Because 3 weeks is too long to find out that someone's made a mistake with a dangerous drug in the wrong box. So yes, you're right. We have to respond fast. I was talking about fast reaction. I totally agree. One thing is that we don't want to create any new structures in the ministry. I think the country has enough structures. So let's ask for the French gendarmerie, maybe if they could have a healthcare unit. If you take 50 of them, maybe you could work with these healthcare crises with the gendarmerie. Well, that's great then. Okay, what about eliminating medical deserts to make them healthcare oases? Well, medical desert doesn't reflect reality in France. There are very few of our fellow citizens who really live more than 10 minutes away from a doctor. That doesn't mean that they have access to that doctor. That's another question. So the question of zoning and the distribution of doctors per inhabitant doesn't reflect the difficulty of access. You can have doctors nearby, but who are overworked and they won't take any additional patients. You can have waiting times for a specialist that are too long. So I think that the question of territorial access to a doctor illustrates better the difficulty than the word desert, which has been repeated over and over, medical desert. I don't really agree with that term. Well, because the term desert would require a single response, which would be populating these desert areas, if you will. And we're not going to be able to invent 20,000 additional doctors, and we don't really need additional doctors. Our density of doctors corresponds to the rate recommended by the OECD. So we need to free up some time per doctor and medical time, which can be paramedical as well in each territory. So I'm looking at the question from this aspect, and I'm trying to see what are the obstacles that prevent doctors today from having diversified practices between maybe their private office and the hospital, and what is preventing them from delegating tasks. These are what we call advanced practices for certain professions, such as nurses, so that they could interact with other professionals via tele-expertise and telemedicine. All of this will be allowed by the organization that we are implementing with a focus on organizational innovation. And our system is very locked by too many regulations. It's not because people don't want things to change, they don't want to implement this, it's because there are regulations. And so we will need to propose exemptions to some of these regulations and incentives so that the territories get organized. Because the problem is not the same according to the existence of care in a territory. You have many specialists in certain areas and no GPs and a hospital, and it won't be the same as in a region where you have a huge group of hospitals with lots of local hospitals but no specialists, and 3 of these healthcare centers that we call maisons de santé. So depending on the region and the existing professionals, we will need to propose innovation to give more medical time to patients who don't have access to doctors. And I trust the local stakeholders. I've told them what the objective is. I want people to have less waiting times to see the doctor. I want people to have less of a feeling of being far away from a healthcare professional. So we'll put a certain number of indicators in place that we'll present next October 13th with the Prime Minister. And we'll be setting up a supervision committee with all of the stakeholders, the unions, the patients, the healthcare professionals, and elected representatives and elected politicians. And if we need to modify a regulation or legislation, then we could put it in the next PLFFS. And we're going to have 5 to 10 years that will be very difficult in the local territories because of the decrease in the number of doctors. And this will make things very difficult in the next 5 years. Now, you're talking about transfer of tasks and skills. You said that these nurse practitioners will be trained to act under the authority of the consultant. Now they will be independent. In other countries, in all of the English, in Canada, Australia, they already have these nurse practitioners who work in osmosis with the doctors, and the nurses are ready for this training. Why are we waiting to do this? When you talked about paramedical, I think these are medical professions with a different level of responsibility. Well, the advanced practices that I referred to involve offering nurses and perhaps other healthcare professionals in the future who would enter the system. It offers them to be trained to a task that up until now was only entrusted to doctors. But we have to go slowly. Our system was not organized with medical assistance, as is the case in the U.S. So I think we have to have a certain time to adapt. And I'm prudent here because doctors are often called very devoted to corporatism because they don't want to entrust any task to other professionals. I don't think that's the case. When a doctor knows a chronic disease and it doesn't require that much complex diagnosis, this is sometimes a restful time for the doctor when he sees an easier patient. So delegating all of the easy patients to the nurses and only reserving the complex pathologies to the doctor, I think that would require a real evaluation of these complex consultations. And so this will allow the doctor to perhaps take more time for these complex visits, whereas doctors were trying to generate a maximum number of visits, and all of the simple pathologies were useful in terms of his revenue and his practice, and to also have moments of rest during a very heavy workload. So in a healthcare system, you need to support the changes. It requires changes. I think we need to move slowly but progressively toward this delegation of tasks by helping improve certain skills of doctors, and you can't just do this by deciding in the law that we're going to modify the organization of a healthcare system. Of course, you're right. Now, assessing the relevance and the quality of healthcare, what do we do? In France, evaluation is a sanction, whereas in the U.S., assessment leads to promotion. How do we change people's mindset? How do we get people to accept to be assessed and to show what they're doing? Well, today what's important for me, I don't know if it's assessment, but we need to reflect collectively as to what good medicine is and what good medicine is not. I talked to a lot of people who are in the room here, and I think we all agree that the only way to departition our system today would be to ask ourselves the question of what is useful to the patient collectively and not think in terms of operators. Today, due to this pricing, all of the operators are working in silos with the objective to generate activities, and we're not able to think about coordinated healthcare paths, or very little, because they're not promoted as such. So we're not capable of encouraging relevance. A doctor who decides today to not operate, he has no promotion of this choice. He's not rewarded for this choice. So I think the system, it will take time. It's a change in culture, but we need to adapt our pricing modes to these challenges of relevance. We need to avoid redundancy, make sure that these coordinated healthcare paths are useful to the patients, and give ourselves the means to evaluate them, to assess them. And quality indicators, this is what I have encouraged in the past. And so we must look at the quality of life of the patient and the patient satisfaction, and also the relevance of the treatment that has been given. So for me, this is an in-depth change of our system. It's a major challenge for the quality of the system and the sustainability of the system. And you can't do it from the top down. The relevance and quality it's not the ministry that decides. It's the peers, the doctor's peers, and the patients. So it's co-construction of what we call a relevant healthcare path. And so it's a job that I'm just starting today with all of the actors in the system. Now, loosening the administrative straitjacket. Well, when you talk about the administrative straitjacket, we talked about this for medical deserts. A lot of things will be simplified to encourage innovative organizations. And likewise, I've heard Mr. Loiseau earlier in terms of medical devices. He was complaining that there was a complexity of assessment of these medical devices. When I was listening to him, I was thinking that what we're lacking today is something intermediate between pure clinical research and treatment and care. We won't be able to give a price to all of these medical devices without assessing what they provide to the population. So we have to implement a system of assessment, real-time assessment. That's what we call real-time supervision of drugs. And this will allow us to simplify certain approaches for certain companies making the devices. I heard Mr. Loiseau say we need to look at the DM, but I believe that profoundly when I was at the French healthcare. But the medical device has had a market authorization, so it will have a risk-benefit. Well, no, drugs have a market authorization, whereas medical devices have not had that same type of market authorization. So we have to be prudent with medical devices because the legal framework around these medical devices today does not allow us yet to guarantee 100% safety. So you were talking about, what was the term again? Loosening of the administrative straitjacket. Well, loosening means facilitating, but also remaining vigilant, because health is a safety issue for citizens. So we have to remain vigilant by loosening up and tightening, untightening the straitjacket. We need to make sure that we still provide the same quality and the same safety. So it's the at the same time that's very complicated to achieve.
So how to recognize as well as possible private care facilities and clinics or having the public doesn't do anything, and some people say the private doesn't do too much. So we're still saying, in fact, I can't stand these oppositions. I just can't stand that. So we're constantly trying to, are you more for the private? Are you more for the public hospital because of your pasts? Because you're focusing more on public hospitals. But in your family, you're private physicians, so maybe you like the private practices more. So you're a physician, so you don't like nurses so much, or the pharmacist. Stop it. Stop it. I'm interested in the quality of the care for our citizens, for all of us, in fact. And what leads to this, I think, unfortunately, is our pricing system. We have to work together on pricing and be innovative, not to replace the tariffication, the pricing per act, and not to replace the TA either. We have to finance for activity. We also have to encourage people to do better around the health payment systems, around the relevance. So all of these organizations that have been innovative, they've been financed in the United States. We've seen it. And we have to get there in France, not to replace one system with the other, but to encourage people to do better. The ones who do well will be encouraged, whether it's private or public. Physicians, the paramedicals, I don't care about that, who it is. And people who aren't doing well, because there are some, and we can see this attitude in certain professionals, no doubt, and certain industrialists and certain industries. Not everyone is totally virtuous. Well, those who are virtuous will be encouraged, whereas we need them. So our system won't work without stakeholders and participants who are invested into the system when faced with their patients. So I think the vast majority of physicians and the vast majority of paramedicals and the vast majority of industrialists, they want to do well. They want to encourage progress. And the ones who aren't doing well today, well, they just won't do well. So encouraging. You've already talked about a lot about encouraging. So we're still, from the medical industry, we're still in phase 2, phase 1, phase 2, phase 3. When I say the internet, a patient can send, say, the signs that that can be seen. Why does it take so long to market things? We want to be able to see these little signs. Patients are very happy to answer questions by internet because it costs nothing and it's a good, quick response. I have to talk at my passage at the HS. I want to develop indicators of the quality of the care provided to patients. It can't replace quality indicators. We can't forget them. It's something in addition, but it's not replacing them because we can be very satisfied with the Surgical Act, even though it wasn't timely or advisable. So the problem is this is just another tool of these assessments. I'm not going to judge myself for what I did in the past, but we must collectively integrate patients, involve patients. It's the new form of democracy in health with the elevation of our system. They must be actors, not only of their health choices on their own level, but also as part of the collective improvement of the healthcare system, while interacting with health professionals, while giving their opinions on certain health pathway of acts or actions on a daily basis. All this is organized. We have to have solid indicators. It's not just a questionnaire of yes, I'm happy, no, I'm not. We know that that's quite dangerous. It's questionnaires that must be very carefully prepared, assessed. The health authorities starting to talk about this, and I think we're going to be working on these tools in the future. So, optimistic view. Sometimes people say, yeah, we'll get to it, or do you think are you more of a pessimist? We'll never get there. So what's your optimistic view out to 5 years? First of all, sometimes I find that the task is huge. My good fortune is that I've had 35 years of professional life with a vision of different facets of medicine, given my work in different institutions and my work at the hospital. So I have a fairly clear version of where we have to go. I'm optimistic because I think society is mature for this transformation. Everyone agrees that our health system was developed in the 50s. It's not well suited to the challenges of today, of aging and chronic illnesses, and all these words that we've all heard a million times. And we must transform it. I'm quite optimistic because I don't want to do things too brutally. I want to have a shared construction. I think that method will pay off. I'm absolutely certain that the state must be a guarantor of the results. We should have to have a strategic state, and this is the role that I'm giving to the ministry to set objectives as to where we must be going collectively. But but I don't want the state to be imposing solutions. We have to develop these solutions together. So I'm actually quite optimistic, even though I think in 5 years it's going to be difficult, but it's going to be maybe 10 years then. Maybe in 15 with Europe. Who knows? I'm coming back to the relative relevance and treatment quality. When will we have access to results? Now, it's strange in this country. I can give you an example. Urological surgery. We have no referentials on the quality of our surgeons, whereas the doctors are good friends. We know this when we go abroad, but we have no guidelines. When are we going to have to open these boxes? This has been discussed considerably in these 2 days. That's the digital transition, and we're still far from getting there. But I'm fascinated. I was already fascinated before I got to the ministry, but even more so when I got there. But there's a lot of system fragmentation. We've allowed in the hospitals, in medical surgeries, in ERS, all kinds of dozens of systems that aren't interoperable. We haven't had a strategic view on the need, and we are currently incapable of collecting enough health data to share it and to data mine that we would own collectively. The professionals, in order to improve their practice, I've seen it in some countries, it's quite interesting, and even the ministry in order to direct public policy or other actors. So there's a challenge today and a reflection which is strategic. We have a Secretary of State and the digital transition who's extremely devoted to this digitizing health and wants us to be a priority of the government's efforts. So we're working on that. And in the great investment plan that was introduced by the Prime Minister last Monday, we have a budget envelope around 400 million euros dedicated to digital investment. It will be digitization of care offers, but also we're going to benefit from these health data in terms of analyses or big data and decision-making algorithms. So it will also probably be a challenge for the valuation for our technology companies that want to invest in this artificial intelligence. So my subject, I'm not the Ministry of Industry. It's not to develop health technologies. That's not my job. But I'm health minister, so I think that to have health data that will allow us to take care of prevention, to integrate relevance, to recognize our practices and our public benefits, I think that would be a great benefit. So we're going to come in just to finish. So how do you work in this part of the government, which is new, of course? You Marisol Touraine was in the public service 3 times, and you said that. So you said yes, 3 times. And you said that you see her for an hour and a half very regularly. How do you get on with the other ministers and with the government and the government? We get the impression that things are different. We're here with your advisors. We never seen it before. You know, the president's advisor here. So what's going on? Is there something that's working? Is there a new management? Tell me everything. Just to me. No, I think that there's a real desire to transform the country. We may not agree with all the options, but there's a desire to transform the country, and we feel it very much. Even people may have different solutions. We all understand the urgency of this transformation in a world which is very unstable. there's a desire for transformation and to implement new methods. That's transversality, interministerial work. We're not in competition with between our ministries. We want to work together. A method also of listening with and working with people in the field. So a kind of humility compared with what we can do. We can't do anything without people who are really involved in what they're doing, really invested. And this requires that we have to talk a lot with one another, and that's what we do. So we still have 10 minutes because I know you have to leave to fly to Reunion and Mayotte. If some of you may want to ask a question, we have a microphone back there. Who would like to ask a question or not? No one wants to. Good. No, that's not true. It can't be true. We have a microphone. Hello, Madam Minister. It's not a question. It's a thank you from a colleague. Thank you for your position, which is pro-vaccination. Thank you for your pro-vaccination attitude. No, that story's finished. We can't. It's not quite finished. No. We're still going. There are many attacks. It's difficult to put rationality back into this debate. We all know it. In our domain, the truth or rationality has trouble coming to light when there are roadblocks. So when the question of vaccines, it's really complicated. I wanted to reassure everyone. I think I have a clear message. Today, 8 French children out of 10 have the 8 out of 11. We want to get 9 out of 10 children vaccinated in order to meet the World Health Organization's objectives. Eventually we're going to go from 8 to 10 on to 9 out of 10. Thank you. Who wishes to speak? Madam Minister, hello. Pierre Ravoud. I was lucky to benefit from the innovation package, one of the 3, after having waited 5 years. It was difficult at the very beginning. So the question is the following. You were talking earlier about the marketing authority. It's true that as an industrialist that work with the practitioners in France, since we're a French company, research at the INSERM, the practitioners came up with the idea, and the industrialist implements it. The question is the following. Between the ATU and the market purchase, couldn't we find an intermediate solution? Couldn't we have a concerted development? Since today we can export 80% of our innovations that are exported, that are covered, reimbursed in other countries, but not in France. Now, in the PLFSS, your question will allow me to let you know this. In the PLFSS, we have a line called the Innovation Fund. We are accompany organizational innovations, but also organizational that would depend on a new act or a new system, and which would serve to accompany the rollout of these systems or these actions throughout the territory. So the governance is with all of the actors around the table. We will identify projects which are innovative. We will assist with their rollout in areas of expertise. That doesn't mean we'll roll it out with things that are done in the past, because I think it's somewhat more risky. So we want to accompany in certain centers of expertise or centers which would like to invest in a certain system or a certain action. To support this new organization financially, and so the interest of this assessment would be that if it works and things are going well, then we'll roll it out. So it's a kind of temporary reimbursement or temporary coverage. It wouldn't be throughout the territory, because here again, I think that we would get towards a risky area, because not every innovation is free of risks. Sometimes we only can find these risks in real life, so we want to help with the dissemination to these centers of expertise to appraise and to assess, and then to roll things out on a safe basis. And I think that responds to your requests. Madam Minister, you're very attached to biomedical research. We know that. Can you tell us a little bit about what you would do to contribute to practicality and the competitiveness of France in research, and how you're going to work with the Minister for Higher Education. We began the reflection with Frédéric Vidal on clinical research because this is a zone that we have, that's our zone of interface. I asked for an assessment, a recent, of the PHRC, how we could make them evolve. There's also clinical research, which is financed by other actors as well, other stakeholders. There's also the question of the CPPs with the new Jardin line. Well, all of this was as part of a reflection. Currently, I don't have a strategy. I think that there's a challenge to consider the attractivity of French clinical researchers, but I see that there are two very attractive sectors. That we can have strategic visions. We have the ECHA and the NRS, whether in translation illnesses or age or infectious illnesses, which are progressing in France. All the other sectors have collapsed, and I think that it's not just a question of medium term. We have to develop strategic research where the operator identified outputs. I think the clinical research, it can't just be button-up stuff. So at the HRC right now, it's just a question of identifying projects without a strategic view. And so it's a reflection that we're beginning now. There will be answers during the year. We're going to have reflections on the PHRC. Thank you. I know you have to leave. Thank you, Madam Minister. I know you have to leave.